Hello, good morning, everyone. Okay, good morning. We're going to get started. We're already running 5 minutes late. Oh. So it's lovely to see so many people here in the room, and I know we've got many, many, many more people online. I can't remember the exact number, but it's over 100 people or something like that. And Alice is nodding, signed up online. So we're in the room, but we're also in an online space, and hopefully that will work well as we move through the days. So thank you everyone for coming today. I'm really delighted to welcome you to the University of Exeter and to sunny Exeter, a rare sunny June day. So it's really nice that the weather has behaved itself today. And thank you for coming in person for all of you who are in the room, and also thank you for coming online for those who are joining us remotely. My name is Dolezal. I know many of you, but some of you are new faces. I'm a professor of philosophy and medical humanities here at the University of Exeter, based in the Centre for Cultures and Environments of Health, which is in a building just up the hill. And I'm also the PI of the Shame in Medicine project. This is an interdisciplinary research project that has been generously funded by the Wellcome Trust and has been running since May 2020, so for 5 years now. And we're going to wrap up our project May 2026, so in just under a year from now. So this current project has arisen from a collaboration, from many years of collaboration with Barry Lyons, who is here in the room somewhere, my friend and colleague from Trinity College Dublin when I worked there quite a few years ago. Barry's an anaesthetist and a medical educator. And when we met, we were both interested in medical humanities, and I had been researching shame for my PhD and in my postdocs. And Barry said to me, we have to do a project about shame in medicine, because there's so much shame in medicine, but nobody's researching it, nobody's talking about it. And that led us to collaborate, and we got some funding over the years, which led us to get this bigger collaborative award project from the Wellcome Trust, which led us to work with Matthew, who is here, who is the co-I on the project. So I lead the project here in Exeter, and Matthew Gibson leads the project in Birmingham. And other project members are Arthur Rose, a literary studies scholar who's researching, among many other things, shame in medical memoir. My PhD student, Juanita Navarro-Paez, who sadly can't be here today, who is researching shame in visual culture, particularly in graphic medicine and comics. And in Birmingham, we have Matthew Gibson, who's a social worker and sociologist, is that fair? Empirical researcher, I'm never sure what to say, who has extensively researched shame in professional practice, especially in social work. And for this project, he's moved his expertise to look at medicine and healthcare. Stephen Williams, who's here with him, who is a research fellow on our project, and Farina Kokab, who sadly also can't be here today because of illness, who's another research fellow. And so the three of them have been leading a big piece of empirical work looking at negative self-conscious experiences in the NHS among patients, medical students, GPs, hospital doctors, and doctors disciplined by the, or referred to or / disciplined by the GMC. And you're going to hear all about that and their findings in the first presentation, so I won't say any more. We also have our creative facilitator, Mary Robson, who's somewhere over there, who has been an invaluable part of our team, facilitating and holding space for us over the years as we've been working together and figuring out how to work in an interdisciplinary and transdisciplinary way on this topic. And our project coordinator, Alice, who I think you've all been in touch with, who has held the whole thing together over the years. So I'm really proud of this research project, and it's been brilliant working with this team of wonderful people over the years. Shame is a topic that remains taboo in research and in health research. And while it is obvious that negative self-conscious experiences are significant in healthcare for patients, for students, and for professionals, weirdly, there is still very little research on this topic. It's growing, but especially in the UK, there's very little empirical research, or there's not much of an evidence base. So anecdotally, we know shame has a big impact in healthcare, and the UK has produced that show, Embarrassing Bodies, where it's all about shame and illness, shame in the body, but there's very little research about how shame actually makes a difference in healthcare. So we were really hoping to start to fill that gap, especially in a UK context. We have done a lot during the 5 years of the project, and some of you I know have been following the project closely, some of you have just heard about it. We had a little sub-project during COVID that was funded by an AHRC Rapid Response to COVID grant, where we did a piece of work around shame, stigma, and COVID, and we published a book with our collaborator Fred, who isn't here yet but should be soon, which is on the registration desk. It's an open access book, so if you're interested in it, you can just download a full PDF of it from the Bloomsbury website. We've done a graphic medicine project, which is been funded by Duke Exeter Awards and also Wellcome Center Research Enhancement Awards. So if you haven't already picked up one of these little booklets, Alice put this together. It sort of showcases many of the comics, or all of the comics that we made in collaboration with artists and medical students. So all of these comics tell the stories of real medical students who have kind of shared their stories and worked with artists to bring them to life in this visual form. And that was a brilliant project. I collaborated really closely with Will Bynum, Juanita, my PhD student, Charlotte Wu, and then all of the artists that we've worked with. Another output that I'm really proud of, many of you would have heard, is the 10-part audio documentary series that Will and I collaborated on with The Nocturnist, which is a medical storytelling podcast that's based in San Francisco. And we worked with them over several years to make a podcast series called Shame in Medicine, The Lost Forest, which won loads of awards and has been downloaded hundreds of thousands of times. And at the end of today, we are going to have a wine reception in our building, the Queen's Building, just up the hill, about 3 minutes away. And there's an exhibition on at the moment that features the artwork of Beppe Conte, the artist who made the really beautiful illustrations that accompany that series. So at the end of the day, I'm going to lead you up there, so don't go away until you've gone up and had wine and seen the exhibition. And so shame is something that affects us all in different ways, and it's very likely that every single one of us will experience some form of negative self-consciousness about our bodies, about our health status, about our circumstances or lifestyle within a healthcare setting. My own interest in this topic, and I've been researching shame for over 15 years, my research interest in this is driven by my own lived experience of shame and chronic shame, and my ongoing curiosity about why these sorts of experiences can have such a profound effect on what we are up to day, and how it can drive decision-making, how it can shape behavior, how it can shape our relationships with others. I have experienced this firsthand, and it's brilliant to see the academic and research interest in shame growing as the taboo around this topic and experience is lifting. So lots of brilliant people like Brené Brown and others who are like openly talking about shame and vulnerability and psychological safety and things have made this kind of possible to open this space for us to openly address this. So I'm really excited about the conference over the next 2 days. Our aim was to showcase, obviously, our own work. So Matthew and Stephen will be talking mostly about that, but also the research and practice beyond our own project that's going on in the present moment. So we got tons and tons of abstracts, and we had to carefully select some, and then some have been selected to be posters. But we have a really exciting lineup of speakers from all over the world, and also poster sessions showcasing some really interesting projects. So there'll be time in the program for you guys to look at the posters and chat to the people who've brought them along. Talks are covering things and topics around patients, forms of illness, medical students, clinicians, public health, and also we're going to hear about a lot of practical interventions within healthcare spaces that work directly with shame. As I mentioned, this is a fully hybrid conference, so we have speakers presenting in person, but also online. So I think the next panel might involve just online speakers, yeah. And likewise, audience members who are here in the room and also in an online space. We've got a technical team at the back, which are going to run the day, and hopefully everything will run smoothly. So thank you in advance for everything you're doing. If there is a problem online, so if something happens online, what we'll do is just pause what's happening in the room. So please bear with us and be patient in case we do have any technical glitches. Hopefully that won't happen. Everything is being recorded, so if you don't want to appear in photos or in recordings, just let us know and we can make sure that you won't be on any of the recordings we post after the conference. So before I hand it over to our first speaker, I'd just like to thank Alice Waterson for putting this whole event together. Alice has done absolutely everything. I take no credit for organizing this event. It was truly all her work, and I know you've all been in touch with her in some form. She's done a brilliant job. So thank you, Alice, and I'll thank you again tomorrow, probably at the end of the day. And also, obviously, huge thanks to the Wellcome Trust for generously funding our project and also for funding this event. Thank you to Viv, who's helping out on the registration desk, and Che, who is wandering around with a big camera, who's going to be taking photos. So again, if you don't want to appear in any photos, just let us know and we'll make sure that happens. As the day progresses, if you need anything or you have any questions or concerns, you can speak to myself or you can speak to Alice, or if Viv is around on the desk, you can speak to Viv. We're going to have tea and coffee breaks outside, where, like in the front entrance hallway where most of you have already been. Lunch might be on the lawn if it's sunny, so hopefully the weather will hold. Ladies' bathrooms are upstairs, so go back to the entrance and upstairs. Men's are downstairs to the right, and there's a gender-neutral toilet and an accessible toilet down there as well. I don't think there's a planned fire alarm test, so if a fire alarm goes off, we should evacuate and go out this door to the lawn. All right, I think that's all the housekeeping, and without further ado, I'll welcome Stephen and Matthew up for their presentation. I'm really also very excited to hear this. Would you guys like to come up, get your slides up, and then I'll briefly introduce you. Oh, your slides are up. Yep. There they are. Oh. All right. So as I mentioned, Matthew Gibson is an associate professor in the School of Social Policy and Society at the University of Birmingham. He's my co-I on this Shame in Medicine project, so we've been working together for quite a few years. And Stephen Williams is a research fellow on our project, and he's been working very closely with Matthew, and also Farina, who isn't presenting with them today. And unfortunately, she's not here because of illness, but Farina is also a research fellow on the Shame in Medicine project. So all three are based in Birmingham and have been doing this amazing, huge piece of work and data collection around shame experiences in the NHS. And I think we're going to hear a kind of summary of their findings. So I'll hand it over to you guys. Thank you.
So thank you, Luna, for that introduction. So I think obviously Luna's introduced myself and Matthew, and today we're going to take you through the hidden injuries of medicine, findings from a 5-year empirical study into shame and medicine. So in terms of the project overview, we are focusing on shame and medicine. As you can see at the centre, oh, sorry, I haven't changed that, there we go, at the centre of the diagram here. And the reason why we're focused on shame and medicine is that it plays a crucial role in shaping the experiences of both patients and healthcare providers. So this includes influencing relationships in clinical settings, also affecting both mental and physical well-being, as well as contributing to stigma around certain conditions. So by better understanding the dynamics of shame in medicine, we aim to improve healthcare by adapting more humane practices to benefit both patients and clinicians. So as you can see on the slide, we have split the medical experience into 3 work streams. So we have work stream 1, which is the clinical encounter, work stream 2, the medical workplace, and work stream 3, medical education. So I'll take you through these work streams and what they involved and what we asked participants to do a little bit later in the presentation. But just to draw your attention to the 3 bands around the circle. So this represents the fact that, as Luna said, it was an interdisciplinary project, and I think Luna's covered that quite nicely. So just to say that it involved academics from philosophy, cultural studies, and empirical sociology. So we collected at Birmingham, where we were the empirical sociology team, so we went out and collected information from doctors, patients, and medical students, and then we analysed it alongside the philosophers and cultural studies academics from the University of Exeter and Trinity College Dublin. And this led to an ongoing process of theory development, where we identified an evolving theory of shame. We could also then see where there were gaps in our knowledge, and then go out and collect further data, which led then to further analysis and further theory development. So it's just to say that getting to this stage where we can take you through our research findings today has been a real team effort involving multiple disciplines. So in terms of the research questions, the main objective of the research was to investigate shame experiences in contemporary medicine, and there are 3 overarching research questions, as you can see on the slide. The first being, how should shame be theorised and understood in the context of contemporary medicine? The second being, what role does shame play in contemporary medicine? And the third, how does the experience of shame impact on the delivery of healthcare? So in terms of today's presentation, The aim is to outline the empirical research undertaken as part of the Shame and Medicine project. So I'm going to take you through the design and methods that we used, and then Matthew will give you an overview of the findings. So in terms of the research design, as mentioned previously, the research was split down into 3 work streams. So we have work stream 1 that involved patients. So this was the clinical encounter. And then work stream 2 that involved doctors, which include GPs, doctors who worked in hospital settings, but also doctors, I think as Luna mentioned, GMC doctors. So what we mean by this is doctors who are being referred to the General Medical Council, the GMC, which I'm sure, as you're all aware, is the body that's responsible for regulating doctors in England. And what we mean by GMC doctors is that they've been under investigation by the GMC, so they've been referred, investigations being launched. For some of these participants, it concluded, for others, it was ongoing. And then finally, in work stream 3, medical education, we included medical students. So in terms of what we asked the participants to do, in each work stream, they were asked to complete a diary entry detailing their instances of shame in clinical encounters, and in medical settings. So anytime they had an instance of shame, we asked them to record it in a diary entry. We called these emotional experience diaries as they were designed to record participants' emotional reactions to incidents that caused them to feel shame or self-consciousness. So the emotional experience diaries are used slightly differently in each work stream. So in work stream 1, we asked patients to complete 2 diary entries, one detailing their most recent incidents of shame in a clinical encounter, and the other the worst experience that they'd ever had related to shame and medicine. And then in terms of doctors, we asked them to complete 10 diary entries relating to shame in the workplace. And they were asked to complete these over a 2-week working period. And then in relation to medical students, we asked them to complete 12 diary entries in total, recording their shameful experiences in medical education. And this was at a rate of 1 per month over the course of a year. Then the purpose of requesting a specific number of diaries over a certain time period was to collect data both on the major instances of shame, so those events that cause people to feel a deep sense of shame and perhaps humiliation, but also to include emotions that were more mild, such as perhaps feeling a little self-conscious or slightly embarrassed. After completing the emotional experience diaries, participants were invited to take part in a 1-hour semi-structured interview. And the purpose of the interview was to discuss what they've recorded in their diaries in more detail. Throughout the research, as I've mentioned, we collected and coded the data simultaneously, and this was to develop our emerging theory of shame in medicine. So we continually moved between data collection, analysis, and theory development, which enabled us to identify gaps in our knowledge and then undertake further data collection and then theory development. So just in terms here, before we move on, relating to the participant numbers, so we can see we've got 265 participants in total, and it's split down across, as you can see on the slide, so 120 patients. And these patients had a range of both acute and chronic conditions, including both mental and physical ailments. And then in work stream 2, we had, as you can see, 28 GPs, 29 hospital doctors, and 15 GMC doctors. Again, participation was open to doctors at any stage of their career. So this meant that we had doctors ranging from recently qualified junior doctors to trainee GPs, all the way to senior doctors, both consultants and GP partners who were approaching retirement. And then we had 73 medical students across the 5 years of medical school. And within the different work streams, we tried to recruit participants from a diverse range of backgrounds, including gender, class, and race. So in terms of the project timeline, we began our research journey in June 2021, and this started with a pilot research just to test the emotional experience diaries as a tool of data collection. This was conducted with a small sample of patients, doctors, and medical students, and it was completed in July 2021, which then we began the ongoing process of data collection, analysis, and theory development. So this took a total of 39 months, which was split roughly into 6 iterations of around 6 months each. The reason for splitting into iteration was to provide a formal milestone where we could assess the data that we had and the nature of our theory in order to decide where we needed to focus in terms of future research. And then this process went on until October 2024, when we achieved data sufficiency across the 3 work streams. So in total, we received 1,047 individual diary entries, 1,047 individual diary entries, which include 116 interviews across the 3 work streams. And this provided us with a detailed data set, as firstly, the diary entries allowed participants to reflect on experiences which had caused them to feel shame or self-consciousness as close to the event as possibly happening, so soon after it happened. This gave us access to their raw feelings and enabled us to understand their initial emotional reactions. So the interviews were then developed using the diary entries from the patients, doctors and medical students to try and understand these experiences in a little more detail. Being a semi-structured interview, it meant that we could focus on what appeared to be important in the diary entries, but also give the participants the space to develop their own thoughts and feelings during the interview process. So we had a data set which was detailed and included 2 levels of participant reflection, both initially and then later in the process, as the interviews happened after the participants had submitted their diary entries. So just to say here as well, in terms of the interviews and how we applied the methods, we applied them flexibly in the sense, I'm sure as you're all aware, researching shame is quite a difficult thing to do because people don't like thinking about difficult emotional experiences or dwelling on difficult events. So we spoke to the participants when we recruited them and to see how many diary entries they think they could fill out, what time frame it would take for them. Some participants only wanted to complete diary entries, others only wanted to attend an interview. So we sought to accommodate people in order for them to participate in the research and to ensure that they felt comfortable in sharing their difficult emotional experiences with us. So now just relating to the emotional experience diaries, and just run you through the numbers here because as I mentioned before, we had 1,047 individual diary entries, and this split down, as you can see along the slide, to 164 individual patient entries. And these entries tended to focus on patients' interactions with clinicians and other healthcare providers. And then in work stream 2, we had 429 diary entries in total from 215 GPs and 214 hospital doctors. And these tended to focus on interactions mainly with colleagues, but also with patients. You'll note on the slide that we didn't collect diary entries from GMC doctors. The reason for this is that I'm sure as many of you are aware, it's often a very lengthy process, the GMC disciplinary process. It's not unusual for it to take months or even years. And obviously this leads to quite complex emotional reactions and quite detailed events in terms of what happened. So we decided to collect data from the participants through interviews in order to allow them to set this out in detail. And finally, in workstream 3, we collected 454 individual diary entries from students, and these tend to focus on their interactions with their fellow students, also interactions with clinical and medical staff, as well as patients. And just finally here, to run you through the semi-structured interviews. So the numbers, so we had 116 interviews in total, 30 patient interviews. Oh, thank you, Matthew, sorry. 30, I don't think I'll ever get used to that. 30 patient interviews in total, and then we had 60 interviews with doctors, including 24 GPs, 21 hospital doctors, and as I mentioned, 15 interviews with GMC doctors. And finally, we interviewed 26 medical students in workstream 3. So to summarise the research design and methods, it was a process of simultaneous data collection, analysis and theory development that enabled us to understand the shameful emotions of individual patients, doctors and medical students in the context of contemporary medicine. So I'll draw this section of the presentation to a close and invite Matthew up to talk you through the research findings. Thank you.
Our first research question was about what is shame. We're not going to say much about that here because we will publish on that. We're going to focus on the shame in medicine bit. But to say that for those people who were talking about shame, within the diaries, we got people to scale how closely or what word they would describe that particular experience. So, you know, is this a shame experience? Is it humiliation? Whatever. So they scaled it. So when people were talking about shame, these were the sorts of things that they were talking about. Not feeling good enough, not living up to standards and expectations, feeling flawed, inferior, inadequate, failure, feeling insignificant, unimportant, and worthless. So I know there's lots of debate in the theory about shame, but this is what people were describing in the diaries. And for us, it was about this, what we call considering like the situated understanding of the self in the moment. So one way of creating a situation which makes someone feel that they're not good enough can be manipulated or changed or shaped by other people and the context that they're in. So the question is about what is the context that creates those sorts of experiences. The context, you're right, there's 2 buttons to press. The context, theoretically, in some ways, the idea, this is from Larson's theory, sociological theory about professionalism, and this is the professional project that medicine, not just medicine, but all professions have a project to try and create itself as a profession. So it's not just about competence and being good at a particular thing or about public service, it's also a social project to gain market control, to gain control over a particular area. So for medicine, the area is that we are really good at addressing people's health issues. And we have expert knowledge and skills, and that we're really good at this, so you need to pay us more money and have greater status, etc. So there's an element within the professional project to make these claims and to push the entire system, all of the people within it, to have more power, more status through this idea of creating this profession. Now, you can trace that back for as long as you like, but we're currently in, and perhaps there has always been, major threats to that professional project. You know, threats to the particular marketplace, the area that medicine and doctors actually perform. So within the UK, in the health service, we've got the NHS being controlled by the state. You've got people and politicians and trying to drive particular agendas. There's this issue around effectiveness, value for money, and efficiency, and that means that certain things that is happening within medicine are being challenged. You can see that the media is being used quite routinely as a way to try and undermine certain aspects of that. Once you undermine that, you can pick off certain parts of medicine. So perhaps we'll focus on junior doctors, now we'll focus on consultants and whatever. So what you're having is this area where there's this threat to the professional project, where the profession itself has to respond to try and continually prove itself as worthy as the people to address this issue around people's health issues. So that we still have investment in the project of medicine and doctors as a broader thing. So what happens is that those threats are forced into the profession, into the way that the profession operates. And one of the first foundations of medicine. Ah, sorry, I didn't use that slide. There you go. Let me know if I forget. And now it's not working. Okay, right. One of the first foundations for shame is the creation of identities. That's not just in relation to the threat, but certainly in the creation of the professional project of medicine, you have to create a set of identities because they are people who are doing things. So who is doing what? So we have the medical student who needs to be trained up, who becomes the doctor, who treats the patient. These are 3 predominant roles. So medicine has continued trying to prove itself. It proves itself through the people, as well as lots of other things. But when it comes to shame, the big part of that are the people. So these people are having to demonstrate that they are meeting these exceptionally high standards that have been created for medicine. And they are translated into roles and responsibilities, as well as characteristics and attributes that are then infused in the roles and into the expectations that we have of the people that perform these roles. So medicine is seen as an elite group. It's an elite thing to do. That's represented by this particular medical student who says, I don't think there's any leeway for average. You can't do an operation on someone and it's just okay. It has to be perfect. Because if you don't, something will happen later. If you haven't stitched wonderfully, they will have a bleed and they will die. So if it's not perfect, it's not good enough. Now, of course, it's a bit of a tongue-in-cheek perhaps, but that was repeated time and time again by everyone right across the system, that this needs to be really, really good. This is an elite thing that we're doing. We're messing with people's lives. There are serious consequences to what we're doing if we don't do it right. So the standards are incredibly high. So that is the standard which is imposed upon the entire system. So the roles then within, for the students, was that this medical student was incredibly great. They got the high marks, they got the high grades, they worked really hard, they sacrificed everything to make sure that they could do that. They were different to other students. They had to go in at 9 o'clock and they finished at 5, and they had to then go to the library and then they worked. And so you have all of these representations of what it means to be a student. And this one said, the mystical med student that came before me was already so much better than I am. So you've already got this distinction between who I am expected to be and who I am. Creates the foundations for shame. Representations of doctors. This doctor said, I think there's almost an extra level of shame in being somebody who may be meant to be in a position of authority or have a handle on things, and then losing that, and then, you know, crying in front of people. There's that certain extra level that you shouldn't really be doing this. You should be able to, you know, you should be able to manage. You should be able to cope. You should be able to kind of deal with these situations probably, and that's what you went to med school for so long for. That's what we're being paid for. So again, this distinction between who I'm expected to be and who I am, this difference between that isn't just about knowledge and skills, which is embedded within the system, but it's also about attributes, about the way that I am. So now it's not just that I have to be great and get all the great marks and grades, but I have to be really emotionally resilient and really in control, and I have to be able to address all of these really complex social issues as well as all of the technical ones. So the representations are starting to be created and imposed on these people performing these roles, which are beyond just the role itself. So the doctor says, so this is for patients. So it's what do we expect patients to be within the system, not necessarily just what patients expect of themselves, but within what do medicine expect. And so this doctor says, I would call a good patients are people who comply. So when you suggest either regular appointments or medication or whatever, they comply with that they are grateful, that they attend appointments regularly, you know, on time, that they bring appropriate things to you. So all of these features are of a good patient. So that is the expectation really when people walk through that door, because if they don't do that, then they're not considered to be a good patient, and there are problems because you're not performing your role. If you're not performing your role, it threatens the role that I perform, and it becomes problematic. So there are specific roles with specific things, with specific attributes that we're expecting people to do. You know, how hard is it for patients to comply? How hard is it for them to turn up on time? How hard is it for them to be calm and able to communicate their issues in appropriate ways when they've perhaps been waiting for a really long time, you know, months for an appointment or hours in it, whatever it might be. You know, there's lots of reasons why it might be difficult for them to do that, but that's the expectation within the system, that they perform that role in that particular way. So the second foundation then is that these roles are placed in a hierarchy. So this makes sure that there's power and control within the system, there's responsibility and accountability, and there's trust and legitimacy within the entire frame of medicine. So once we've got that, then we can make sure that we can prove to the wider world and to the people who are invested in medicine to maintain the professional project that this is something which is meeting these extremely high standards. So, but once you've created these hierarchies, it affects the normal social interactions of comparison and competition and navigation and negotiation. So what it means is that we're always navigating and negotiating our social interactions. How should I be in this situation? What might I say? How might I say it? But once you've got this very formal hierarchy, that changes what I might say and how I might say it to who. And it then starts to create a different set of comparisons. So now there is a very specific comparison about how I am with other people who are on the same level or above me, and how do I get to that particular point. And now I'm in competition with people who really should be part of my support network. So we're starting to create a second set of a formal hierarchy. So at the bottom, you've got patients. So So if you can imagine a triangle, it feels to me like the consultant is at the apex of the triangle, and then you sort of have a cascading system with the patients at the bottom. Student says, I do look up to consultants like a mini god. A doctor, consultants, they're the top dog. You don't mess with anything they say. You know, they're the absolute boss, and that's that. So the thing with that is that that means that they can talk to you in ways which you wouldn't ordinarily be able to be spoken to in any other aspect of, like, you won't go up to someone and talk to them with disrespect. But within the system of medical with the formal hierarchies, that's allowed. So in the same way that how you speak to a student and maybe how you can speak to patients. So the formal hierarchy changes the interaction and the relationships. But it also creates informal hierarchies about who is within my group, within my section, who is at the top and who isn't. So we've got a doctor here saying, I'm the only doctor in my family, no one went to university in my family, so I always felt a bit of an outsider. So this doctor feels that they're not part of the group, and certainly not with the same amount of power and status as others who are equal in their terms of role, because they don't have the same social components, because how medicine or how doctors are framed was that there are certain types of people, not just a role, but a certain type of person who perhaps has a history of medicine in their family, who went to decent schools, potentially private schools, who are predominantly white, male, middle class, and those sort of other wider sort of social areas which provide power and status are also then translated into the system within medicine, within the formal hierarchies. And then we get a student here which sort of reflects that. I think the idea of the med student being a white, male, middle class person still exists, and I think there's that kind of punishment for if you don't fit into that criteria. So that's how people were starting to feel that I don't fit, not just my role, and perhaps I'm the best medical student there is, but I just don't fit because I'm not a white man. Even though predominantly female student body group, etc. It's still the idea that there is this representation of who doctors are is still being provided within the system. So once we've got a set of ideals around who performs this role, how they should perform this role, and how they are in performing this role, we use that as a foundation, as a guide to decide what is legitimate, appropriate, and necessary in terms of my interactions, in terms of what I might say and how I might say it. So once we've got that guide, then it can be that people can feel shame simply because people are doing what they're expected to do. And that's an unfortunate outcome of the way that the medical system works. But equally, we can use shame in a very purposeful and strategic way to let people know that they have failed to live up to the expectations and standards that have been set within the system. So what we're calling systemic shame. So this is like, no one is attempting to shame someone on purpose in systemic shame. It's simply that we feel shame because in an attempt to try and fit into the system, we don't. And then we feel inferior or inadequate or worthless. As an example, this patient says, it was kind of like, get the job done and then try and put a new one in me. Just felt like, it felt very clinical, which I know is funny because it was a clinical setting procedure. But it just felt like I wasn't a person in that situation. I was kind of just the patient to have something taken out of me and then have something put in, and it just felt like dehumanizing. They're performing their role perfectly. The doctor is performing their role perfectly. This is how the system works. But they feel incredibly ashamed about what has happened because they don't feel that they are a person within it or being taken, the whole entire person is considered. So the system works as it works, but they feel shame because of it. Another sort of situation, the student was an overweight student trying to put on the gowns to go into theatre, but they didn't fit because they were all the same size. So she's attempting to try and put it on and Velcro up. She says, I wanted to just sort of melt into the floor. I didn't want to be there anymore. I was desperately trying to get the Velcro to fit, and any movement I did just ripped the Velcro. So nobody in that situation was trying to shame her, but the very fact that everything was designed on the basis that people look like this and are this sort of body shape didn't fit, and therefore they ended up feeling shame because they're not fitting into that system. And that can be spanned right across the system in so many different ways. But then we have strategic shaming. So these are the things that most people, when you say, you know, tell me about shaming, this is what people talk about. So a patient says, upon taking a medical history, she started shaming me for being difficult to medicate because of my complex health needs and medications. She insinuated that I had no reason to be in pain on pain medication and just to grin and bear it. So it's because this patient's not fitting into the ideal. So there's something wrong with you rather than something wrong with the way that the system works. Student says, outside of the room, the consultant approached me and began in a harsh tone to tell me how rude and disrespectful I had been and how they would never have dreamt of saying something like that at medical school. Of course, I was taken aback, embarrassed, ashamed, but I did not expect what happened next. She walked away, clearly muttering to herself, and came back again to tell me how horrible my actions had been. She carried on for what felt like forever and left me to the point of tears. So they were 10 minutes late to the appointment. And then the doctor says, we'd just finished our post-take ward round, and in front of 2 surgical trainees, my consultant said, by the way, you did well this week. Not brilliantly, but well. So again, all of these are messages about the way that they're not fitting into the ideals. They're using these as a way to impose upon people. You should fit into it like this. And if you don't, I can legitimately say there's something wrong with you, rather than us questioning the system of understanding about what we're expecting people to do or be. So this strategic shaming can come in passive comments. It can be active comments, as I've sort of shown. It can be the strategic use of an audience. You know, I might say something to you. I could choose to do it in private, but I could choose to do it very publicly, which is often the case because it reiterates the point and lets everybody else also know that that's the standard that is going to be imposed and you have to live up to it. But equally, it could be a system, an attempt to try and degrade your identity in the minds of everybody else. So I can then say, look at this person over here. They are completely incapable of doing what they should be doing, and we all need to believe that. Right? That identity degradation is what part of the GMC process is, but it also lives up in lots of other ways. Yeah, sorry, you didn't remind me. So now, once you've got a system of ideals, and then you start to impose them, you've then got people trying to navigate that system. So people are now struggling to live up to these ideals. But generally, people want to live up to them. I want to do a good job. I want my health needs to be met. I want the doctor to be able to do what I want and get fixed or addressed, cured, treated, whatever it might be. So people are trying their best to do what is expected. But that can often lead to a level of inner conflicts between who I believe myself to be, who I want to become, and how I am experiencing myself within the medical system. Because the medical system is created in a particular way, as we've sort of seen. So how do I understand myself within this system, and how does that relate to who I think I am? That creates these conflicts. So some of those are personal struggles. So a patient said, I was almost ashamed of myself for not standing my ground and speaking up for what was important to me. And then, you know, almost playing the role of some sort of submissive patient. That didn't sit comfortably with me, really. So they were doing what they were expected to do. They were living up to those standards. But that left them feeling ashamed because I'm letting myself down. And then the doctor, everybody seems to think that you're an expert in the thing that you're doing, and obviously that's not always the case, and so it can be difficult to ask for help, and I think it feels, you know, you should be able to. So again, I should be able to do this thing, but actually I can't because I'm a human being, and I can't know everything and do everything and be everything that everybody wants, but that's the expectation. So there are these personal struggles to live up to these ideals. There are relational struggles in that other people are providing you with information all of the time that you're not living up to the thing that you think you are or you should be. One student says, I have to explain my name and where I'm from and how to pronounce it and where I grew up and why I have an English accent, you know, maybe 3 times a day, and it's exhausting. I'm just trying to be a medical student and try and do the thing that I'm expected to do and apply my knowledge and skills, etc., in this particular moment. But now you're telling me that I can't be that because there's something about me that says that I'm not living up to your expectations. So now I'm having to explain it. So that level of that struggle to live up to those things can be imposed by other people. A doctor, the sorts of things that make me feel self-conscious are things like, you know, the sort of almost your expert patient, your person who's come in and has all the research on the internet, and now you're presenting what they think they do or don't need doing for them about a subject that you probably don't know anything about. So you've got a situation here where the system is set up as the doctor is the expert and the patient as the not expert, and the doctor provides them with the information and the treatment. But it's sort of flipped because now this relationship is actually they know more about this than I do. And I can't let them know that I know more, that they know more about it than I do. So I'll sort of play along and sort of go along with it and end up giving them things that I don't think they should have, but I'm going to do it anyway, and I feel bad about it. So these relational struggles of trying to live up to these sort of ideals can be quite difficult. And then there's the whole health system itself. How does the health system facilitate your ability to do the thing that you're expected to do? And sometimes it doesn't. So you do feel shameful because of the whole system. I guess such a good kind of place where it's not my role as a doctor that's wrong, but it's not being able to kind of perform my role as a doctor because of the situation you're put in. Not having the right equipment, not having the right place, mistakes happening on administration, all of those sorts of things are more systemic, but actually reflect on you as a doctor or as a patient or as a student. And I sort of struggle with that because now I'm looking foolish. So in an attempt to live up to these ideals and the messages that we get and the systemic shaming and the strategic shaming, sometimes that can end up with a form of harm, in that it can harm practice, just what I am doing in the moment. But it also could harm me as myself. Like it can fundamentally change the beliefs and the values and the things that I hold about myself, because what I did believe now no longer has the weight or the foundations. That these other experiences that I've had have undermined those, and now I've got a whole set of other experiences which are starting to form an idea about who I am as actually unworthy and incapable. So this is what we're referring to as shame-related harm. So we can see, and with this patient, so this is the sort of low-level harm, if you like. I'm always on edge when I'm going for a medical appointment or receiving a phone call. It's like I'm on edge and I'm waiting for criticism or judgment. So it affects the relationship. It's very difficult sometimes for patients to interact in a way that is expected, because those experiences of being shamed form the basis of my interaction. I am anticipating you judging and criticizing me, so I'm actually going to change how I'm going to say it, or sometimes not say it at all, and sometimes just not even go. The doctor says, I struggled to concentrate for the rest of the day. I was worried that the consultant was going to complete an incident report or contact my senior. So again, the whole entire day is shaped by that shame, because actually now I'm no longer able to be present and to provide what I need to. Perhaps I'm not remembering the information that I need to remember. That changes the relationship. And then another doctor says, I practice very defensively. And I'm always very worried about, we should all be worried about, what if I'm missing something? But I think it probably impacts my ability to accept risk. So again, they're just describing their previous history of shame affecting their current practice and interactions and relationships. But it can be more fundamental than that. So this student says, it definitely changed me. I felt like kind of broken inside. I felt like I was going to take my own life. The only reason I didn't was I didn't want to be a burden on my family, who were trying to encourage me. It would be okay, and do whatever they could to help. So they'd received negative professional judgment from the doctor who was assessing them in placement. And that fundamentally threatened their idea of themselves as a doctor, or their ability to be a doctor. So not just in the moment, but I don't think I can ever be a doctor because this criticism demonstrates how terrible I am, how unworthy I am, how incapable I am. And so if I can no longer be a doctor, which is so important to me, then actually there's no point in living. It threatens my identity and threatens my entire self. And that was a really, and we have that with students and we have that with doctors. But it also happens with patients. So the way I was treated genuinely made me feel like these people would rather I take myself to a country with euthanasia than be bothered to help me. It is something that's caused permanent trauma. And she did go on to talk about thinking about going to another country and thinking about euthanasia, because her experience of the health system was that she was not being taken seriously, that anything that she went was so traumatic, so humiliating, so shaming, that she just wasn't able to face it, because she started to come to believe herself and understand herself as this lesser human being. And then we can consider shame-related growth. It's not the opposite of shame-related harm, because in some ways it's that you have to experience the shame for shame to actually be a trigger or a facilitator for a sense of growth. And this is where experiences of shame can indicate, well, it does indicate disruption between who you want to be and how you are, and that can then either make you question yourself completely, or it can make you question the system. And then if you question the system that is being imposed on you, you can come to say, well, it's not me, it's the system. Actually, there's something about me that's all right, and I can redefine or recommit to things that are really important to me, my values, or the ideals that I hold about myself, or certain things that I think are really important about what makes me. If I recommit to those, or I can change those, and then I can feel more me within this system, it feels like personal growth. So one patient says, I guess all experiences help you grow in some way or other, don't they? I guess it just flagged up the need to fight my corner, to be assertive, where I naturally perhaps wouldn't. So the expectation was to be submissive and be compliant, but actually what this taught them was that they shouldn't be submissive and compliant, and they should be more assertive and stand up for themselves, and that makes them feel better about themselves. So it felt like a form of growth. A student says, I think the predominant residual feeling is of growth. It's a strange feeling because it replays in my head in a positive way. I now approach patients differently, make sure I am more thorough, and I feel most conflicted by how the teaching style, which was about being shamed and humiliated, has somehow succeeded in improving me. It has muted my confidence in clinical examinations, but also motivated me to keep on growing. So for this person, that they saw themselves in a way that they didn't like, and then they could change their path or their understanding and change how they were presenting themselves, which made them feel more them, and that made them feel like they were growing as a person. And this doctor says, I try and make it easier in being myself as much as I can. I mean, I'm one of these people that will walk through the corridors of my trainers vaping. Do you know what I mean? Because I try and let as much of my natural self out as I can to counteract the fact that I do have to do this performance. So what's happening in this growth is this distinction between what I'm expected to be and who I am. And I'm not merging the two, which is part of what happens in harm, is that the two become merged and I can't see myself as being any different from how I'm being represented within the medical system. Whereas in growth, I can distinguish them and say, I'm an all right person, and actually I can represent myself in this way and live up to the ideals that I have and try my best to live up to this system. And even if I get a bit criticized or judged or whatever, that's okay, I can live with that because this system doesn't work properly. So that's how people can start to feel that it's a form of growth. So humane practice is sort of at the corner, is one of the cornerstones of medicine, and it's sort of embedded in a lot of the guidance around how to be a doctor. So the idea about respect for the whole person, being compassionate, communicating, and being in partnership with your patients about care, all of that is embedded within medicine itself. But we still have these experiences of shame right across the system. And so one of the things that I think we're arguing is that shame sensitivity needs to be a cornerstone of how to create and perform humane practice. And that is to acknowledge that people experience shame. And it's quite amazing how many of the doctors that we spoke to sort of said, patients don't really feel shame, or their shame is really only about the body. It's not quite the same as our shame, because our shame is really terrible, and it's not the same. So there's this lack of acknowledgement that, you know, across the system there were these people who did feel shame in lots of different ways. And then there's this sense to avoid shame and shaming, the strategic shaming, or designing systems so that we don't actually end up shaming people because we haven't thought about them or thought about the way that they might interact with medicine, and then address where shame is experienced. Like the number of people that said, well, this happened, but then they came to us and said, this was really important, just to say sorry, that went a long way. So addressing that shame, and potentially where it was traumatic, you know, there are lots of things that you can do to help people and refer them on, and perhaps additional services which might help to address the sort of deeper level of shame. But even just small interactions, shame-sensitive interactions, can be deeply profound. So this is a patient said, I would reflect and realize that that experience with that kind doctor was the first reminder to me that I am worthy of being cared about, even by a total stranger. The experience was one of the first to teach me to be kinder to myself, to treat myself with more patience and empathy. It definitely made me more likely to seek out the appropriate healthcare for my needs in the future. As I know now from experience that there are good, genuine doctors who want to listen to you. You just have to find them. So this was just a fairly fleeting experience, but the doctor acknowledged and respected what they were experiencing, and they felt that that was a really important thing for them in terms of challenging some of the foundational beliefs or the core beliefs that had come to see themselves as inadequate. And now I can see myself as a human with flaws, but that's okay, and I can grow. Thank you.
We've got, let's say, 10 to 15 minutes for questions, and then we're running over already, but we can chat more in the break. For the people online to hear, I'm going to pass this roaming mic around if anyone in the room has questions. And then how do I see when people have questions online? You guys will let us know. So we'll alternate between the room and online. If there are questions online, we can alternate. So would anyone in the room like to ask a question? Yes.
Hi, thank you. Lovely, lovely data and lovely results. Thank you for doing that. Now, my question is this. I don't know whether you have, in the UK, more so I think in many other countries, the step from being a junior doctor, so-called, the term that we're trying to get rid of, to a senior doctor, the term that probably is not quite appropriate, is a big step. There seems to be a lot of induction, training, and quite a big change in the mindset of how you should behave, portray yourself, and how you should manage the staff beneath you. So I was just wondering whether that would be a difference of data if you compare the two. You only have N29, I think, for hospital doctors. That's right. But I don't know, I can't remember how much data you collected from them, because I think it's going to be quite different how a so-called doctor in training perceives shame and how a consultant does.
I guess you're right in that there's limitations in any data set, in that our concern was getting a spread, breadth, rather than necessarily depth in each of the different strands within the hierarchy. And the numbers for us was the important numbers for us was the number of experiences, in that's like the diaries would demonstrate as close as possible to the experience, what was going on, like across a 2-week period, how many times have they experienced self-consciousness and shame, and in what context, and how was that affecting what they were doing or understanding of themselves. So I wouldn't say there's a huge amount of data that we've got that shows that, but what we can say, whether you're a student, a junior doctor, or senior consultant, there was a very similar pattern in that the expectation was you should be able to do it before you become it. So students should be able to be a doctor before they graduate, so that when they do graduate, they can be the doctor. And that junior doctors should be able to be a senior doctor before they are a senior doctor, because when you are a senior doctor, you just have to be a senior doctor. So for them, the concern was, how do I be this thing when no one's even telling me how to be it? Because no one sort of told them, because they're not in a position to be told that. And so for students, it was that I'm supposed to have all this knowledge and skills, and I've only sort of had, 6 weeks on this thing and whatever, and now I'm going on and doing this, and that feels really scary. Or the junior doctors were like, well, I'm going to be that person, and I don't know how to be that person. So everyone there's a level of pretense. You become that person, and then I'll just sort of muddle along and copy some other people, ask them, and you get a sense of solidarity between a group of people that you trust. And you go and talk to them and say, right, well, okay. And then they have an open communication, but then there's the front with other people where they don't necessarily want to let them know that they're struggling with that. So I guess that's what I can say to that. Is that maybe not what you wanted? Right,
more funding,
yeah.
Is there a question online, Emily?
We have 3 questions online.
Okay.
We'll start with, were there any emerging themes around disproportionate shame experiences by social class, gender, race, sexuality, especially among medical students?
Do you want to answer it?
Absolutely there was, yeah. I mean, in general theme with medical students was, I think, as Matthew's alluded to, the idea that they should be able to be a doctor while being a student. And, the sort of sense that they weren't good enough. And this was compounded by the fact that often medical students are often very bright people. They've got good results at school. They've been sort of in the top sort of sets for everything at school. And then they come into medical school and it's a realization that, they feel like they're struggling and they're going to struggle. And that is compounded even more for students who perhaps are from less affluent, less privileged backgrounds. Because they don't, I think, perhaps have the family history. Seems to be a lot of family history in studying medicine. So that, someone's dad or mum was a doctor and it runs through the family. And that gives those people then an extra sense of support as well, in the sense of that they've got somebody else they can talk to, which perhaps somebody who comes from a home where they don't have any history of medicine or even going to university will lack. And then it's the idea that still, although, as Matthew said in the presentation, the student cohort is now predominantly, I think, female, there's still very much a sense of medicine being a male profession, being a white profession, and all this obviously then builds into this sense of inadequacy, which then means when they do struggle, they get further feelings of shame and self-consciousness.
Thank you.
Thank
Questions in
you.
the room? Mick, go ahead.
Mick Grazer from Rochester, New York. And I'm curious about the shame-related harm, especially in the trainees, physician trainees. And I don't know, I thought about, you brought to mind, there was a huge survey that was reported in the New England Journal in 2019 of surgical residents in the US. They got over 90% of them, something like 7,000 respondents. You're familiar with that. And they talked a lot about abuse. They experienced verbal abuse, abuse about their identities, and the harm that they described was at high levels of burnout and suicidal ideation. And I'm wondering if you alluded to some of it in your comments, if you were able to code or look at the journal or the interviews in terms of that kind of abuse experienced by trainees, physician trainees, yeah.
There were some who were at that sort of level that were considering taking their own lives. Taking up too much time. Not a great deal, but there were some, and that was the same right across the thing. And it was because, and so for us, the harm was that their identity had become so intertwined with their idea of being a doctor that when the doctor identity was threatened, it was a threat to the whole self. They couldn't distinguish the difference between me and me performing the role as a doctor. And so it became easier to harm someone when their identities were fused, because any sort of rejection or criticism or judgment was experienced as a form of harm. Because it's not just that you're saying that I'm not performing that very well, but I'm actually an all right person and there is a difference. You're saying that I am an unworthy and incapable and inadequate human being to actually perform this thing. So, if you can't do that, and in the most extreme of some of the really extreme strategic shaming, where you're really putting people down and showing them up in front of everybody and trying to make them feel humiliated, Like, you're degrading their identity in their own minds by saying all of that stuff that you believe about yourself, that's not true. This is the truth, that you're a terrible human being and you're completely incapable. But not just that's embedding in you, but I'm embedding it across everybody else, because now everybody else believes it too. So now if I think that I believe it myself and everybody else believes it, that completely shatters my connection with everything that I believe about myself. So I might as well take my life, because there's nothing there. So there were some, not a great deal, but there was enough there to show, and that was reflected for students as well as junior doctors who are training in different fields.
Can I add just one more thing? In this study, not only was there shaming from the hierarchy, senior doctors, but there was a discussion in the report about shaming from patients toward the trainees. Does that show up in your interviews at all?
Yeah. So we sort of see it as it's the medical system. So you're performing a role within it, and you're sort of trapped within it in a way, because it's not just it's easier to see those who are imposing the ideals down, but everyone else is also invested in these ideals, because if you're not, the whole entire system of medicine sort of falls apart. So you do have other people going, well, doctors should be white men who are really great at night, whatever, or doctors or students should be sacrificing their lives to learn all this stuff. Why have you got a job? So everybody is invested in the same system, so you're sort of trapped within it. So it becomes really easy for you to fuse your identity, because the system asks you to. So the actual people who distinguish themselves from that are very few and far between from how it is nowadays anyway.
I'm going to go online and then we'll come back. So Emily.
What I heard was that if patients are impacted by shame in medicine, they can be referred on for support. However, there is a huge amount of shame in psychiatric medicine. What's your view on this? Do you think doctors should be taught how to be trauma-informed / responsive?
Yes. The question, I guess, is who is the most appropriate person to address the shame or the trauma? And that may or may not be a doctor, and it may or may not be a psychiatrist. And particularly for those people who've experienced a great deal of trauma and shame, humiliation within the psychiatric system, may very well not want to go and see a psychiatrist or being part of that psychiatric system. So I think that it's about medicine or the health system having a number of different avenues to address people's shame. And that, I think, might be, counsellors or support workers or facilitators or whatever it might be. Support groups were really important to people, not just about other professionals, but just having other people to talk to. That can be a really important part of it as well. So I think a range is important, not necessarily just medicine addressing, it's not burdening, the system with more expectations.
Yeah, thank you so much for your work, and I really hope that you're able to share it kind of at higher levels, in terms of government and kind of national and international conferences, because I think it's so important. But I guess I'm really interested in, either from this research or just your thoughts generally about cultural variation. So where the NHS is coming up to 80 years old, and in the UK, I think, I remember a previous supervisor of mine talking about the NHS as a kind of container of society's anxiety. So we can't bear to think that the NHS might be filled with serial killers like Harold Shipman, or paedophiles, or people that fail. And we can't sort of bear to think about that in society, and we almost project our own anxiety into the NHS, and therefore kind of perpetuate that because of the nature of it being a free healthcare service at the point of entry for all. And I'm just wondering whether you think, that impacts on any kind of international variations in how people perceive and manage shame kind of in healthcare. And I'm wondering about more evolved societies, like maybe how I perceive New Zealand, for example, with more psychological kind of maturity and shame sensitivity. I don't know. I think.
Do you want to say no? Yeah.
Shall I go first? Yeah, I think it's a really good question, I think. And I think what you've said around perhaps the culture around the NHS in Britain, in England, where we're researching is really important. I mean, we had some people who responded to our request to be participants by telling us that they'd never experienced shame in the NHS, and everyone who works in the NHS is an angel, and this research is badly motivated, because obviously I think people are concerned that it could undermine the NHS and then we'd move to a fee-paying system. So there certainly is a cultural thing around the NHS and what people expect of doctors. But I think it's also interesting in terms of what's expected of patients, and I think this can sometimes lead to shame, because going back to when the NHS was founded, you went to the doctor told you what to do, you didn't challenge the doctor. Now there's a whole thing in the NHS, well, are people patients or are they consumers, advocating for themselves? So I think there's a lot of different things and a lot of different cultural expectations. But in terms of international comparisons, I think it's really difficult. I'm not sure if Matthew will be able to say more, but for me to say, because obviously we've been studying for 5 years the English healthcare system. And there is, I think, a sense within perhaps England and the UK that this is the best system. And I'm not really convinced that it absolutely is in every aspect. So I think you are right that we could learn more from other systems.
I think the difficulty with containing people's anxieties socially is that we have this system set up to say that the medicine addresses this need, and it suits medicine to have the idea that they're sort of superhuman, because that helps the professional project, even though that's damaging to the people who are within it. And I don't think society tolerates the idea that, well, we pay for this service, or, we're going to this thing, you're doing this thing to me, and you might make a mistake. Like, people don't want to tolerate that. And also we don't want to promote that in a way, because that's the human side of it, isn't it? Like, humanity becomes a problem because humanity is the thing that can actually make you not do the thing that you're supposed to be doing. And we built a system which is supposed to, you do this particular thing. And you'd have to, I think, have a wider societal change, a cultural change. And whether they have that in New Zealand, I don't know. I mean, I did work in New Zealand, but not in medicine. And they have sort of similar issues, social issues. And it's just that once you've got media and you've got people who aren't really going to spend much time thinking about it, you've got this thing where it becomes it sells newspapers. So I think it's a bigger thing, yeah.
Doctors are actually, probably higher up the scale in terms of having some narcissistic traits. And so I think, there's a lot of complex kind of things going on out there that create this kind of quite perverse relationship. And
Absolutely, yeah. And, how do we have a system that identifies that as a problem rather than as an advantage? Because narcissists can present incredibly powerfully and draw a lot of attention and feel very capable, which is sort of what people want, isn't it?
I should acknowledge there are a lot of doctors in the room here.
Just to undermine everyone. Yeah, sorry.
Can we have one more question from online, Emily? And then I think if anyone in the room has a question, the opportunity will be to chat to Matthew and Stephen on the coffee break. So just so we don't start running over time. Thank you.
Thank you. We have one more referencing the slide about talking about those undertones of submission. This person was interested if any of those taking part understood how the violence of that act can seriously re-traumatise vulnerable patients, whether there was that understanding there.
Say that again, sorry.
I guess I was interested if any of those taking part understood how, referencing the slides that talking about the undertones of submission, how the violence of that act can seriously re-traumatise vulnerable patients.
For the patients themselves, did they recognise how that affected them?
I believe so, yeah.
Some yes and some no. I think there was a feeling. People had a feeling. You walk into the room or wherever your conversation, you can feel the hierarchy and you can feel the power and status and you can feel the expectations. And so people responded in a way which most of the time was trying to live up to those expectations. And people could sometimes say, I don't want to be like that, but I'm like that anyway. And I don't even know why I'm like that. You know, I'm a professional person and I go and see a doctor and I sit there and I feel like I'm not this professional person that I am in any other respect, you know, so they feel the hierarchy and the power and the status. And so some people could sense that that was affecting them. And then for those people who had a whole range of historical experiences that were harmful, that could then feed into that. And it was very triggering for them. And then they were, often, they were the ones saying, I'm not going. And we had people saying, I'd rather have cancer than go and have this treatment. I don't want any more children, but I'm going to have children if we get pregnant because there's no way I'm going to go to the doctor and have that conversation. Or I do want children, but I'm not going to go because that sort of treatment is really bad. So there is an acknowledgement. So it depends where you are on the scale. The more extreme it is, the more recognizable it was that was affecting them or harming them.
All right, thank you very much. Just join me again in thanking Matthew, Stephen, and Farina for this work. I'm just going to speak here so people online can see. Oh, sorry. We're going to take a break. We'll have 15 minutes for the coffee break. So you all, if you're in the room, you know where the tea and coffee is, and bathrooms, etc. So come back for 11, and if you're online, you can take a break now, and we'll be back on at 11. So thank you.
Yeah. Thank you.
You probably know the joke about the medical student in the operating room. This is a good one for your talks. The med students in the operating room, and because you could never do it perfectly because you're just a med student. Yeah. Sometimes you were allowed to snip the sutures. Maybe they'd let you. And the question was, you'd ask the surgeon attending, how would you like the sutures cut? Too short or too long?
Very good one.
Yeah, yeah. The command.
You have proven, comment not on your word.
Oh, right,
You've
yeah.
actually proven to me what I always suspected. My background is in clinical medicine, but I'm doing research in child psychology. So I'm involved in interviewing students to be medical students.
Right, yeah.
Emphasis. Now, everybody by the time they reach there had gone through the exams. So there's nothing to talk to differentiate because everybody has gone to the CAT exams and everything, to get to that point. So we focus on ability to convey yourself clearly and empathy. Very important component in medicine, which they tell you from the very beginning as a doctor. But I noticed from your presentation today, because you picked up the main themes, only one patient, and it was a patient, it wasn't a staff, that mentioned kindness and empathy. All lost in training, and I suspected it all the while in Britain, which is so demoralizingly wrong in how we're training doctors. Because what has happened in Britain is, in the guise of we don't have the time to do this, it's been given, the job has been to nurses. So if this conference was about shame and nursing, we would have a totally different thematic analysis. Totally different. And that's why there is actually an enmity between nursing and medical doctors. I don't know if you didn't interview nurses.
No, no, no.
It's been going on for generations, from the time of Florence Nightingale until now. It's been going on. There's always this, we always rub each other the wrong way. Because the nurses always feel the doctors are never kind, and doctors feel we don't have time for this, so we needn't be kind. But that's exactly what is wrong, because I feel one of the solutions, in my opinion, of helping medical students who feel demoralized and feel suicidal is to realize that actually, on the basic of it, if you are kind and empathic to your patients, you may have made mistakes. That would actually bring you through. At the moment, my trust, we have actually another newfangled thing that added to our mandatory, our annual mandatory training. Not that I don't have enough. Called duty of candor. Have you heard of it?
Yeah.
That's right. And this is actually I was waiting for this to happen. And it came on I think it was after the COVID stuff. So annually we had to go and listen to this 1 hour talk. But it's so important because it's this lack of duty of candor that was a problem. Everybody's just becoming like imposter. We can do it.
Absolutely.
So I thought I'd just say that you've proven to be right. So yeah, good. But we need more funds to compare the junior and the senior doctors.
Yeah, absolutely.
Because they are totally different, very different.
Yeah.
And I think it was wrong to differentiate this. I feel, I don't know, I haven't trained in the States. Australia is very much like UK, so I've been there. So yeah, I feel that in the States the hierarchy is a little bit less. There's even more responsibility in training. But here there's a big jump. There's a big jump. And maybe because it has
2212.
but there's still litigation in the US.
Yeah, it's different sort of twist.
of our conference. I'm Barry Lyons. I'm a clinician and medical educator in Dublin, and I suppose just to say a couple of things, I've been part of this project since its inception in, was it 2014? 14 or 15. And I suppose for me, as Matthew refers to me as the top dog in the healthcare system, never having felt that way, it has been a very personal journey in many ways, and I've learned a huge amount about practice, about systems, and about myself as the project has continued along. And I think as a researcher, it has been enormously interesting and gratifying to work in an interdisciplinary group. And I have, I suppose, learned so much from my colleagues in this process. So this first panel has two speakers in it. The title of the panel is Patience, Shame and Stigma. And our first speaker, Emily, is Professor, I'll just wait until she pops up. There we go. Hello. Our first speaker is Professor Paula Muhr, who is a visual artist and researcher and currently Professor of Transdisciplinary Studies at the Brand University of Applied Science in Hamburg. And the title of Paula's presentation is The Burden of Visibility, Functional Seizures and the Relational Experience of Shame. Okay, Paula.
Hi, thank you very much for the chance to speak here and present my work. Shame is something that has only come up recently within my broader project, where I've spent many years working on what is currently called functional neurological disorders, but what has this long history, medical history of being known as hysteria. And the focus of my talk is on patients who are currently diagnosed with what is called functional seizures, but even within the medical context, how sort of contested this symptom is probably best designated by the fact that there are still many concurrent terms. They also refer to as psychogenic, non-epileptic and dissociative seizures, and they entail uncontrolled muscle contractions, altered sensation, and for many people who experience them, also loss of consciousness. They still remain very difficult to distinguish from epileptic seizures in clinical context, and as sort of they have been known for quite a long time as hysterical attacks as the quintessential symptom of hysteria. And before I actually come to the main part of my talk, where I want to sort of talk about experiences of shame within the patients that I'm currently interviewing in a Berlin clinic, I just want to give a very short overview of the historical context, because it really sort of importantly shapes cultural perception of hysteria that sort of then trickles into how these patients are treated nowadays within the clinic and also within the broader cultural context, and how they also perceive themselves. So just very briefly, probably the most sort of historically well-known treatment of hysterical attack was by Jean-Martin Chacon, 19th century neurologist, who used photography to differentiate between hysterical and epileptic attacks, and whose photographs have really sort of had this extreme cultural visibility and still remain quite known. What is less known perhaps is that Chacon regarded hysteria as a purely neurological disorder, and he argued that it was caused by something that he called a functional brain lesion, so a kind of localized dysfunction of the brain. By 1900, his neurological approach was dismissed, as misguided, and his pupils, Piaget and most of all Sigmund Freud, introduced these purely psychological theories of hysteria, where they argued that the symptoms were actually expressions of suppressed traumatic psychological experiences. And while sort of Freud's model dominated medicine in the beginning of the 20th century, by the mid 20th century, Freud's theories started to be questioned, and hysteria suddenly became something that was considered not a real disorder. And there were very sort of different approaches regarding hysteria, either as a sort of abnormal illness behavior or coded expression of distress. And it led to its fragmentation and relabeling with many different names for the disorder. And as a sort of consequence of this reconceptualization and relabeling, patients came to be increasingly mistrusted as simulators. And there's really sort of this discourse in the medical literature then from the 1960s about the difficult patient, problematic patient, attention seeker. So somebody who doesn't really have a genuine neurological or organic or even psychiatric or mental disorder, but who somehow just sort of tries to get attention from other people and misuses the medical system to do so. Parallel in the humanities, there has been an increasing criticism of Charcot's research within what is sort of in medical context called by Marc Micale as Charcot studies. It has been argued that the gross and florid symptoms, especially what is by that meant is the hysterical attack, ceased to exist in the course of the 20th century, and that Charcot didn't photograph a genuine symptom, but he trained his predominantly female patients to perform hysterical attacks and then photograph these performances. So basically what has emerged in the meantime in the literature, in the humanities, is that using images in the clinical research and diagnosis of hysteria is entirely misguided. Then I want to point to another sort of development within the medical context, that first hysterical attacks were renamed as non-epileptic seizures, and that was really sort of a renaming that signaled that the symptoms were not understood as a proper disease in its own right, but as absence of another genuine disease, in this case epilepsy. And while most of the other hysterical symptoms have been left undiagnosed through most of the second half of the 20th century, these sort of hysterical attacks were often misdiagnosed as epilepsy. And basically the usual way of diagnosing them was comparing EEGs, so brain activity, because epileptic seizures have a certain sort of recognizable pathological pattern, whereas functional seizure patients don't have these pathological patterns. But this differentiation is, even for specialists, not very straightforward. An additional development was that in the 1980s, there was an introduction of a new technology where video and EEG start to be used synchronously, so that the behavioral features were recorded together with brain activity. And there was increased focus on the fact that a lot of patients in epilepsy clinics had what is called intractable seizures. They didn't react to medication and they didn't react to surgery. And in this context, it was suddenly discovered that unexpectedly many patients, around at least 20 to 30%, actually might have what is now called functional seizures. This in turn led to increased research on semiology of functional seizures and to the identification of certain physical features that now sort of underlie the current diagnosis. And although video EEG is now the sort of gold standard in clinical context, what is also done when EEG is not available is that basically just based on the physical features of the symptom, a diagnosis of functional seizures can be made. Despite these developments, the diagnosis of what I will now refer to exclusively as functional seizures is still highly stigmatizing, especially also in the medical context, and a lot of doctors still doubt its reality. There is still very strong psychologization that sort of implies that because it doesn't have an underlying EEG pattern that is pathological, that these symptoms might still be all in the head. And patients continued to be predominantly female, which also sort of through this gendering increases doubt in many cases. Which finally brings me sort of to my main aspects. So these video EEG recordings are done in epilepsy centers normally, where most of these patients actually get diagnosed because their diagnosis is too problematic to be performed by sort of practicing neurologists outside of centers. And while video EEG is used as a diagnostic tool, so for specialists, some neurologists have started showing select videos to patients in the process of explaining to them the diagnosis. This is something that has been done more systematically and consistently for epilepsy patients, but has now sort of become a new thing that is also sporadically done for FND patients, so for patients with functional seizures, but it's still not a standard practice in this case. And the assumption when showing patients these videos is when they see these videos and when they see sometimes EEG recordings, even if they're shown nothing basically, so the absence of pathological patterns, they will be able to understand their illness better and to accept the diagnosis because it will be grounded in these physical features that are shown to the patients. And since May 2023, I have been performing an ethnographic study in collaboration with a neurologist at the Berlin clinic. And basically the main focus of this study is exploring the consequences of viewing such seizure videos for patients purely with FND, for patients with epilepsy, and for mixed patients. And in this clinic, I'm only focusing on 18 to 24-year-olds because this is the population of this particular department at which I am working. And this is also a very sort of typical age when a lot of these patients also get diagnosed. And basically, while my main focus is on understanding the effects of viewing these videos for patients and trying to develop guidelines of how to improve this whole procedure. So how does it actually, and under which condition, help patients, and how does it possibly harm them, and how can these harmful conditions be optimized? What sort of kept coming up through the interviews is the mention of shame, explicit, but also sort of very clear cases where implicit and unexpressed shame was coming up. And shame is something that within the context of FND generally, but also psychogenic non-epileptic seizures, as they are still called in this context, has not been explored much. So far, there have only been a few studies published by the team around Mark Reiber, who's actually based in the United Kingdom, and most of them have, so the focus of this study has been exploring the role of shame as a potential etiological factor and also obstacle to the treatment. And what they have focused on is what they call shame proneness and patients' shame dysregulation. However, what I'm interested in and what sort of has been neglected so far in this research is patients' subjective experience of shame, especially because these symptoms, so these seizures, are highly visible. They are, for many patients, often very dramatic physically, so with their whole body seizing and trembling. As I said, most of them lose their consciousness, so they have no memory of what actually happened, and the first confrontation with how the seizures actually look to other people is either through how these seizures are described then by their family and friends, or in many cases also by these videos that they then are shown in the clinic. And because they often happen without patients knowing when they're going to happen, they're also very socially disruptive as they happen in situations that can be very sort of challenging for most patients. And this brings me to my 3 case studies that I want to present and to discuss how personal experience of shame differentiates or how it varies between these 3 case studies. These are not the only ones, but I sort of chose these 3 because they show the spectrum of the cases that I've come across so far. So case 1 is a 19-year-old female patient who lives alone and who's training to be a nurse. She had her first major seizure just a few weeks before the interview, while she was surrounded by her colleagues. Since 2017, she has had what she calls repeated absences. So unlike the seizure that she experienced, where she had very sort of pronounced motor aspects, during these absences, she would just sort of lose her consciousness for a few seconds, freeze, and then come back. And while initially these absences were attributed to epilepsy, it soon became clear that it wasn't. And then basically she was dropped out of the medical system. She also reported very strong social phobia, and she described that when she was watching the video of her major seizures that she experienced then when she came to the clinic to be diagnosed, that she had a very strong sense of dissociation. So the doctor showed her her video as she was seizing, and while she was being explained the diagnosis and being explained why the diagnosis was made based on the features of her video, she told me that she suddenly heard a voice that was sitting on her right shoulder and telling her that the person in the video was not her. And then another voice in her head was telling her that it was her, and these voices kept quarreling throughout the entire video. When I asked her explicitly about feeling any sense of shame about her videos, she expressed it very eloquently, and she talked in quite a lot of detail about the shaming effect of not having control over her body in a very visible way for other people. And she also explicitly related it to her social phobia. But in addition to that, she also talked very explicitly about the diagnosis itself being extremely shameful. She expressly wished to have epilepsy and not functional seizures, and her explanations for wanting something that is maybe an even more sort of organically problematic and difficult disorder was that her seizures, although they were diagnosed as functional neurological disorder, so a neurological disorder within the clinic, other people around her would necessarily perceive them as purely psychological. And then she went in great detail into public perception of psychological ailments as not treatable by medication and therefore not real. And she explicitly used all this vocabulary about attention seeking and simulation that I know from the literature on hysteria and FND. First, she really sort of tried to ground this experience or this sort of perception of FND as shameful and as not real to her work experience and how her colleagues in training and sort of the grown-ups and sort of the big fish talk about these seizures. But later, almost at the very end of the interview before we parted, she suddenly talked about her personal experience of dismissal of mental disorders. So almost in passing, she mentioned that her 2 brothers, younger brothers, both had mental illnesses, autism and attention deficit hyperactivity disorder, and that her initial absences, which sort of were left undiagnosed, were really sort of extremely psychologized by the doctors that she met at first. And she explicitly talked about her family being extremely overwhelmed by the mental illness of her brothers. So what at first really sort of looked like this very familiar discourse from the literature about sort of stigmatizing effect of the disorder itself turned out to be grounded in very personal experience of stigmatizing effects of mental illnesses. And the fact that, as I said, that FND was presented to her as a neurological disorder did not help, because she kept talking about how other people that she has to work with and deal with on a daily basis would not accept this explanation. The second case was an 18-year-old patient who also lived alone and who experienced her first major seizures just a few months before the interview. In addition to her seizures, she already had a diagnosis of major depression and PTSD, and she explicitly reported years of severe neglect and physical abuse by her immediate family. She viewed her seizure videos repeatedly during the diagnostic encounter, and she told me that it was her own request. She really sort of spent a lot of time on the videos, and she wanted to see as much details of her attacks as possible in order to understand them better. So she really sort of immersed herself into it. But she also told me that later on in the clinic, she experienced much more intense, physically intense seizures that were also recorded, and that she would never accept viewing these videos. Now, the most sort of insightful aspect of her shame experience was that she described watching her body out of control as very uncomfortable, referring to how vulnerable she was in this situation. But she made a very explicit differentiation between this uncomfortableness. So she told me that she was uncomfortable by the fact that doctors and nurses were seeing her in that state and being able to watch the videos. But she said that in that case, she didn't feel shame because the medical persons wanted to help her. But the intense feeling of shame in her case arose when she thought about the possibility of her family seeing these videos. And she grounded it in the fact that they would immediately label her as being hysterical and exaggerating her effects. And she also talked about her family's explicit rejection of her illness, and that after they heard about her diagnosis, which was not epilepsy, that they refused to visit her in the clinic. She further talked about how her shame from her family was so intense that she would do everything in her power to avoid seeing them, seize in front of them, and would rather sort of stay alone, even if it means that she could get hurt and would need help. And in fact, she even internalized this feeling of shame to the point that she said that she wanted to not believe that these seizures actually happened until she saw them in the videos. And also, like I already sort of said, the shame was somehow also related to the physical intensity of the video. And this brings me to the last case, to the third case, of a 19-year-old young woman who still lives with her family and who recently finished her school. Her history is a bit longer because her major seizure started a year before the interview, and she had multiple neurological consultations before. And some of these doctors that she visited before asked her family explicitly to film her seizures. However, she refused watching these videos that were made by her family, and she only agreed to watching her clinical seizure video, as she said, to help the doctor establish the diagnosis. And in her case, I would really sort of like to advance the argument that there is a case of hidden or unconscious shame, because when asked explicitly, she told me that she's not ashamed of her symptoms or of the videos. But while she was talking about this process of watching the videos, to me, her voice kept breaking. She started whispering. At one point, she also started crying, and she kept changing her postures, almost trying to hide. And then she also sort of related how she struggled with viewing the video itself, and that while viewing the video with the doctor, she started crying when she saw her family's reaction to her seizure. This sort of relation between crying and her family was at first very sort of unclear, but again, almost at the end of the interview, she started talking about experience of seeing her youngest brother first epileptic seizure, and of her family's extremely panicky reaction, and of her mother trying to hide her brother, and how every time his epileptic seizures happened afterwards, the mother would hide her brother and close the door behind him so that none of the family members have to witness the attack. Then I asked her explicitly how her mother reacts to her current attacks, and she sort of acknowledged that now she also closes the doors behind her, and her explanation for the whole thing was that her mother tries to protect her and her siblings, and in a sense, there was a very sort of clear conflict in her case between feeling that she's burdening her family through her seizures, but also her individual need that she doesn't want to be alone when she seizes, and she wants to be surrounded by support. Which brings me to the conclusion, is that from my experience of talking to these very young patients, the experience of shame is highly diverse, very context-specific and relational, shaped by their illness histories and presences of trauma in some cases, previous medical experience, and sort of socio-cultural context, while broader stigmatization and these cultural stereotypes of FND as all in the head play a very significant role, especially in younger patients. More attention needs to be paid to interpersonal relations and especially to family dynamics. And labeling these patients simply as shame-prone or having a shame dysregulation is, in my view, too simplifying and also potentially shaming. Thank you.
Okay, we're going to take questions after each presentation. So there's excellent.
Thank you, Paula, for sharing your work on FND, particularly the functional epilepsy variant. I was just wondering, you made a very astute observation that family interpersonal relationships could be a pivotal factor in the manifestation of this functional epilepsy. I was just wondering, because your age range was 18 to 24, did all three cases were 18, 19, 18, I think something like that, or 19, 18, 19 years old. Did you see that same family dynamic issues in the older patients who would probably be living away from home by then?
I only interviewed so far one patient who was in her mid-30s, and this is because this department where I'm working at has this sort of organizational structure. They only have patients until 24. They actually have also children, but I don't interview children because that would be another context. Parents would have to be present and everything. But everybody who's above 25 goes to another department. So that's just a sort of structural thing. And in this one patient that I interviewed from another department who was in her mid to late 30s, there was nevertheless quite similar family dynamic because she was still living with her parents because she was unable to work and sort of very dependent on their support. But that's a sort of single case, and I cannot generalize from that single case. But in all the cases that I've talked to that are younger patients, and in these cases I chose them for these specific sort of versions of shame, but I also sort of interviewed the ones who are in the early to mid 20s. This family dynamics can take different forms, but in all cases, it has been hugely important, and especially sort of for how they experience shame in relation to their symptoms and to the illness.
Thank you. Will?
Hi, thank you so much for really thought-provoking presentation, and I especially appreciate the ethnographic methods, which clearly have allowed you to identify maybe additional dimensions of shame that people may not be able to express themselves. My question is, I would agree with you. I think that maybe labeling a patient shame-prone within this type of a situation is overly simplistic and harmful. I think you could, from what it sounds like, we could maybe agree that the act of having a patient view themselves on video is high risk for shame, and that experience, especially in patients with complex histories, can be harmful in and of itself. Have you already, or do you anticipate in the future, providing guidance to the neurologists in this clinic about how they might mitigate that risk if they continue this practice?
Yes, that's exactly sort of the main focus of the entire ethnographic study that I'm doing. So because the material is so rich, basically I'm drawing very different study potentials from it, but it started as something which is really sort of aimed at this practical, with this practical aim, right? So that I really want to find out under which conditions and for which specific patients the viewing could be more harmful than useful. Because that's also sort of, that's something that I explicitly asked them, and also sort of try to, sometimes it's difficult for them to give explicit answers. So it's the whole idea behind the semi-structured interviews is to sort of draw out conditions under which the viewing is useful for them, and a lot of them say that it's useful, and it becomes obvious that it sort of brings them a lot. For instance, one of the patients that I presented recognized in the video certain premonitory signs that she was not aware of, and now she's able to sort of react to her attacks and to prepare herself to sort of sit down and react to them. And without the video, that wouldn't have been possible. But it's also very challenging for them and very shameful, and in some cases more than in the others. And the 3 cases that I brought are sort of the more extreme cases, because I wanted to talk about sort of specific shame cases.
Great, thank you.
We have an online question. Sorry, Luna has a question.
Unless there's someone else. Thank you, Paula. This is a really great talk, and yeah, really interesting project. I guess one of the questions I had was, when you spoke about the 3rd case, you talked about how that person didn't self-report shame and in fact denied shame, but nonetheless, when you sort of spoke to them, you identified hidden or unconscious shame. And it's something we've grappled with, I think, attributing to shame to people who deny that that is actually part of their experience. And it's kind of an ethical question, because suggesting someone feels shame can be harmful, and it's also shaming, I guess. So how did you grapple with that?
Thank you. I was really hoping that that question would come up, because I was also sort of grappling myself with that, because I explicitly asked her if she felt shame, and she said no. And then I really sort of went to the literature also to look for these cases of sort of unconscious shame or hidden shame. And there was also a bit of a trouble that they, a lot of times in the literature, then sort of related to how it sort of then gets transformed into aggression or other sort of mental disorders, which I didn't find in this case. So in a sense, also in the literature, I didn't find the right tools for this interpretation, but I sort of wanted to go along with it anyway, because I really had a feeling, and like I said, at first, like if she hadn't talked about this moment of closing the doors that started with a brother, and it was very sort of complicated. The whole scene was very complicated. I didn't have time to go into much detail, but sorry. So she's now already a sort of grown up, but the scene with a brother happened around 10 years earlier. And she was a child, and she was the one who found her brother seizing and called the family. And then this sort of closing of the doors started happening with this brother who had epilepsy, and his epilepsy sort of stopped. He grew out of it. And then years later, she develops these new seizures that are not epilepsy, and she's one of the few patients who don't wish having an epilepsy, sort of like the other 2. But the closing of the door suddenly begins again, this time behind her. And this is something that she didn't even sort of explicitly intended to talk about, and I even couldn't have known how to ask about it. But I just sort of asked her if there was something in the video while she was watching it that triggered a memory that she didn't have consciously for a long time. And that's how she started talking about this sort of closing of the door. And that's why I thought, okay, it's enough. I don't want to shame her by sort of saying that she has an implicit or unconscious or hidden shame, but I really have a feeling that in a sense, she struggles with this personal need not to be left alone when she has a seizure, which she talks about very explicitly, that she needs people around her, but instead having people around her, the doors are closed on her. And she explicitly talked about how her mother wants to protect her and how she doesn't want to burden her family. And she has a really bad feeling that she burdens them. That's why she also cried when she saw them experience her attack. So I really think, for me, the only way to explain this very sort of complicated family dynamics is through this hidden or explicit or sort of unconscious shame. But I also don't have a proper term. I think I will have to find a better term for it, because I really find it inappropriate how this unconscious shame is sort of conceptualized in the literature, with this sort of implicit idea that it's then bypassed into something that becomes damaging and aggressive towards other people, because this patient is, if anything, self-aggressive. But I also don't want to sort of pathologize her in any way. I just think that she wants to justify her family's reactions, and in a way she can't sort of do that without saying to herself that she's burdening them with something. And that's why she started crying. So I'm still sort of struggling with this, and maybe you have a better idea of how I could sort of approach it. But for me, the only way was this idea of some kind of shame that she's unable to admit to.
Thank you, that's very useful.
Thank you very much, Paula. In the, I do have questions, but in the interests of time, we need to sort of move on. So I would like to thank Paula very much for her presentation.
Thank you.
Okay, we'll seamlessly transit to our second speaker.
Hello, can I go ahead and share my presentation?
Great. So our second speaker is Dr. Monisha Madhumita from the Saveetha Institute of Medical and Technical Sciences in India, and Monisha is a practicing dermatologist, and the title of her talk is Beyond the Diagnosis: How Intersectional Identities Shape Stigma and Care in Skin-Neglected Tropical Diseases. Thank you, Monisha.
Thank you so much. I'm very excited to be here at the Shame in Medicine conference. Is my screen visible? No problem. Hello and a very good morning to everyone. It's about 4:15 p.m. here in India, Chennai. I'm Monisha, the Assistant Professor of Dermatology at Saveetha University, and I'll be talking about, how intersectional identities can help, they shape shame and the kind of care that we provide in skin-neglected tropical diseases, and how best we can help our patients. So I'd like to thank the 300 plus participants, community health workers who helped make this study possible, and to all those still suffering in silence, we hear you. So to provide some context, I'd like to take all of you from the UK and bring you back here to Chennai, India. It's a city in the coastal region of South India. Now, the context for us to, better understand the experiences of individuals here requires sort of reframing certain ideas that are slightly different in South India as compared to the UK. And important among that is the existence of the caste system. While a discussion of caste is an entire topic on its own, but I'd like to emphasize how caste systems are different from class structures in that caste systems are rigid. They're designated at birth based on the family that you're born to, and they cannot be changed at all. So in terms of the individual ability or effort to change your caste, it's not possible. It's quite rigid. Next, coming to community visibility and shame. Now, this is of course a broad generalization, but cultures in Asia, specifically India and South India more so, are, centered around communities, right? We're centered around a very important, sense of belonging, and individualism or individualistic pursuits and choices are often not encouraged or even actively looked down upon. Therefore, acceptance in the communities that we live in, it can be our families, it can be the societies that we're a part of, are very important, and that shapes the experience of shame. Thirdly, strong gender norms. So when we talk about gender roles and gender norms, and this I'm just referring to the broad strokes of men and women, but otherwise as well, there are very strict gender norms and expectations. And, high up on that for women is marriageability and fertility. So when it comes to experience of any sort of illness by women, these two factors, that is the marriageability of that individual or how qualified they are to get the best possible groom, and after which, the sooner that they're able to give birth, these factors play into how illness is perceived in women and experienced by women as well. And finally, and before that, religious lens or karmic lens. So illness or any negative experience by individuals are viewed through a religious belief or religious lens, that there is an element of punishment or there is an element of karma. That is to say that, in past lives, our deeds have led us to experience an illness or experience any unfortunate event. And finally, the concept of access or trust. Government-led healthcare plays a very important role, right, in the experience and participation in healthcare. So government-led healthcare in most cities is free of cost and it is accessible. Although there is a very large difference in terms of the ratio between individuals who are able to access healthcare and the doctors available, government-led healthcare again is very important. But what I'd like to emphasize on is we have two major systems. So we have private healthcare and government. So private healthcare is readily accessible, has high quality devices, but is very expensive, which means that for more than 90% of individuals, it's not going to be accessible. However, it's viewed more favorably than government-led healthcare. So with these factors or these areas, which I hope provides adequate context, let's now move into, our topic for the day. So I'd like you to meet Meena. So she is a 26-year-old Dalit woman from Chengalpet, Tamil Nadu. It's a small town in the southern state of Tamil Nadu. Dalits are considered as scheduled castes or groups that are lower down in the caste hierarchy. So she was diagnosed with leprosy, which is a skin-neglected tropical disease. So for those of us who aren't really aware of what skin-neglected tropical disease are, I'll be touching on that in the next few slides. Right, her hands bear visible signs. So leprosy is a skin disease that affects nerves predominantly, resulting in loss of sensation, because of which there is a subsequent loss of fingers, and there is a very visible deformity or visible sign that an individual has been afflicted with leprosy. Because of this, she has stopped attending community gatherings, and her engagement, her marriage, which was planned, was broken. And she is afraid of being stared at, pointed at, and being publicly shunned, because of which she does not attend the local PHC or primary health center. Now, these are health centers available at villages, which provides a basic level care. So in her case, rehabilitation was very important. Taking care of the wounds on her fingers and feet was very important. She avoided this purely out of the feeling of shame, right? And she says, they don't need to say anything. Their silence is enough to shame me. She was one of the first people that I met when we started out on this project. Now, the Shame in Medicine project and conference has been something that has inspired my work greatly. But sort of the push to get this project started was my encounter with Meena. Now, coming to what skin-neglected tropical diseases are, I apologize for the typo. It's tropics. Skin-neglected tropical diseases are a group of infectious conditions characterized by chronic skin changes. So this includes ulcers or break in the continuity of the skin, nodules, patches, thickened areas of the skin, and very prominent disfigurement. Now, it's caused by a host of infectious agents, so bacteria, parasites, and viruses. And why it's called neglected is because in terms of the priority that it's been given at the national level and at the global health level, it has been neglected thus far. And it often affects the most impoverished individuals in tropics and subtropics. So the diseases include leprosy, where there is prominent nerve and skin damage, very stigma heavy. Lymphatic filariasis, where there's swelling up of the limbs, or elephantiasis, it's called, with recurrent infections. Mycetoma, a fungal infection where there can be progressive tissue damage. Cutaneous leishmaniasis, where there is, ulcerative lesions. Yaws, where there are bone and skin lesions in children. And scabies, which is very, very common and with intense itching and secondary infections. Now, these diseases are very visible, but they're very neglected as well because they tend to affect the poorest of individuals. There is a large amount of underreporting that goes on in social invisibility. But the term skin-neglected tropical diseases have been adopted by the World Health Organization, and now it's gaining a lot more importance. So why is shame relevant in skin-neglected tropical diseases? The disease being so visible, shame gets embodied. And again, it's not going to exist in isolation. It's going to be shaped by caste, gender, and poverty. So there is an element of social construction here. And there is a lot of silencing because it prevents people from seeking help, accessing care, even if it were to be made available, and speaking out. And it's, of course, extremely stigmatizing, wherein the shame gets internalized and then reinforced by the community to which we belong. And like I mentioned, communities here in South India are highly influenced by social acceptance by individuals around them or their communities. So in the case of skin-neglected tropical diseases, shame is not just emotional suffering, but importantly, it's also a public health barrier because they're just going to fall through the safety nets available or the screening programs where they just don't want to seek care. So why do we focus on shame? Like I mentioned, shame by itself, of course, needs attention, needs to be addressed. But more than that, in resource-limited settings, like where I come from, we have seen that it is a very significant barrier. It prevents people like Meena from accessing resources, even if it were to be made available, from accessing timely care. It silences their pain, and it manifests in social withdrawal, there's delayed diagnosis, and a whole host of, psychological trauma. And this study seeks to unpack these layers of shame in skin-neglected tropical diseases. So coming to the methodology we adopted, it was a mixed methods approach where we had 300 individuals surveyed across 3 high-burden districts. And these are, of course, districts with a high level of poverty as well. 45 in-depth interviews were conducted using narrative and trauma-informed techniques in association with local NGOs and in collaboration with colleagues from the Department of Psychiatry and Psychology. Grounded theory was used to analyze qualitative data and thematic analysis to focus on shame, identity, and care pathways. So coming to the anatomy of shame. So there are aspects which are felt internally, feelings of dirtiness, feelings of unworthiness, and it also is so much more magnified in skin-neglected tropical diseases because a lack of hygiene is considered a risk factor, yes. However, not all individuals with skin-neglected tropical diseases have a lack of hygiene, which goes to show that there is a correlation, but there is no strict association in terms of that, everybody with a skin-neglected tropical disease is lacking in hygiene. So the internal perception of the sense of cleanliness or sense of, hygiene, again, is altered. And there is a lot of interpersonal aspects to this feeling of shame, wherein there is a sense of rejection, gossip and blame with institutional. Now, I would be amiss if I weren't going to discuss the aspects of institutional stigma and shame that has been, perpetuated by healthcare providers. So there is a significant amount of neglect, scorn, and lack of dignity that individuals with skin-neglected tropical diseases experience in healthcare settings. To just give you an idea, so this is Selvi, a 31-year-old lady from Cuddalore. So she had, club hand from the time of birth. However, when she developed leprosy later on, she says, when they see my hand, they pity me because it's, by birth, congenital. And when they see my foot, they fear me because they believe that she is cursed and anybody who comes in her path is also likely to get cursed. So as I mentioned earlier, religious beliefs play a huge role in shaping shame. And Ravi, a 13-year-old boy from Tiruvallur, again, a rural district in Tamil Nadu, suffers from chronic scabies, a very common infectious disease which causes severe intense itching. He belongs to a protected tribal community. So he says, I scratch until I bleed, But what hurts more was their eyes. So he often spoke about how he wasn't able to attend classes because in his class, his classmates and the teacher, blamed him for lack of hygiene, blamed his parents that, they weren't taking good care of him, because of which, he developed scabies and he is at risk of, spreading that infection to his classmates. And as a result, he has dropped out of school. So why I like to emphasize on this is because when you talk about Selvi, there is the aspect of that she was originally, she had a disability to begin with, which was a club hand. And then, that worsened or magnified the shame she experienced from leprosy. And when we talk about Ravi, he comes from an impoverished community and a protected tribal community. Again, a community that has been at the receiving end of a lot of oppression and violence from dominant groups. So we can see how these shape the way in which the same disease can be viewed in two different individuals, say one belonging to a protected tribal community and one of the communities considered to be upper caste. Thus, intersectional shame results in an intensified marginalization. Now, coming to the other insights we saw with the study, we used the experience of shame scale developed by Andrews et al. Women were, 37% higher in terms of their shame scores. They experienced greater shame. Individuals with disability, the time duration that was taken for them to access care, whether it is for diagnosis or follow-up, was 2.3 times longer. Dalits and those belonging to low socioeconomic groups reported that they were twice as often to experience verbal humiliation at the hands of healthcare providers. And because of which, because of the feeling of shame, there was a 60% drop in follow-up. So these programs are already limited by, lack of resources and lack of funding in healthcare workers. And the aspect of shame now further complicates this scenario where individuals don't come for follow-up, don't take the required treatment, which in leprosy can be as long as 2 years. And this results in not only, the individuals having greater risk of complications and disability, but there is a greater spread of the disease within the community. And I believe that this could be one of the factors that has resulted in India being one of the largest contributors to the number of leprosy cases globally. Despite us having a robust program, we've not really addressed this aspect of shame and stigma actively. And 71% of the Dalit participants stated that shame and not cost was the main reason why they delayed care seeking. And 62% of the female respondents reported avoiding community health workers because they feared being publicly embarrassed or humiliated because of their visible skin condition. Now, a few quotes and a few stories. Now, I just want to add that these stories were not rare. In fact, they were extremely common, and every individual had a story of, shame and discrimination that they shared. So, a young married woman aged 28 with lymphatic filariasis. Now, this is a condition which causes, it's transmitted by mosquito bites, and it causes, very large swelling of the limbs. And that can affect their mobility, it can affect their predisposition to skin infections, and largely we see a lot of them dropping out of schools, dropping out of formal employment networks because of this condition. Now, when it comes to a young married woman at the age of 28, like I spoke about it at the beginning, once a woman is married, the next immediate demand placed on her is to give birth to a child. So once the swelling began, she says, my in-laws, that is her husband's parents, said, I can't be a mother. And they made my husband sleep in another room. So we can see how clearly the experience of shame, right? This is not just by the person with filariasis, but her family and her mother-in-law and father-in-law who have experienced shame on her behalf have now resulted, in separating her husband and herself. Right, and the next case is that of a daily wage worker, aged 51, with untreated mycetoma. So this again is a condition that causes swelling of the feet and, secretions or pus discharge that happens regularly. And they report, we're too poor to hide. The rich can treat it early, and they're right. There are very good antibiotics available for the same. I can only pray it doesn't get worse. So in their aspect, we can see that if they were to, leave a day's worth of work and come to a government hospital for care, it's going to take the entire day, and that results in loss of earnings for the individual. And a Dalit woman, again, age 34 with leprosy, she says, they saw my sores and whispered, oh, of course, she's from that caste and that's why she has this illness. And she says, at this point, I'm not even surprised. So we can see how, shame embodies itself in different ways. It interferes with a couple's intimacy, to very clear economic implications, to, caste-related discrimination and oppression. So as I mentioned, caste and disability were two prominent factors that stood out in our study. And caste was, of course, the most significant predictor of compounded stigma. So when you have a disabled Dalit women, they were the most affected and oftentimes even invisibilized. And many participants were denied even minimal assistance, which is mandated by government programs, and they were just referred elsewhere with dismissive and hurtful remarks. Healthcare encounters. So this is an area we're trying to actively work on, but the systems of caste even permeate healthcare systems. So providers often lacked sensitivity. Patients were scolded for being late or unclean. And again, just to provide context, a government hospital or a government health center in India, any government hospital, treats more than 2,000 patients a day. And our outpatient clinics or outpatient departments are just teeming with individuals, and there is no real privacy for screens available to examine individuals, and there's no confidentiality. So you can imagine a young woman coming in to get her skin disease or skin lesion checked, and there is no privacy available, and the doctor is going to be discussing her condition out loud, which means that there is a greater likelihood that somebody from their community or their village is around overhearing this, and that eventually results in a lot of gossip and spread within their communities and a lot of isolation of these individuals. So for them, seeking help from formal healthcare systems is often quite disastrous. So health centers or health care centers become another site of humiliation rather than healing. So what can be done? So when we think of solutions, it's very important to acknowledge that healthcare systems in developing nations like India have two important resources in scarcity. So that's time and money. So our average time that we take for one patient in busy OPDs is 2 to 5 minutes. And when we're talking about skin-neglected tropical diseases, they're so extensive, it requires a very extensive examination and workup of individuals, counseling to ensure that they receive appropriate care, and the time is just not available. And secondly, money is an important factor. When we talk about introducing shame literacy and cultural safety programs within medical training systems, we lack the funding to even create such programs on a large scale and implement it and ensure its sustainability. This is especially important not at city-based centers, but in community health centers and health workers from affected caste groups across villages and towns in India. And with these two resources being scarce, it's very difficult or challenging for us to provide safe, dignified, and anonymous care options, but we need to be innovative, probably utilizing digital tools and technologies. And that's an area we're really seriously considering to provide adequate, informed care for individuals and to fund long-term psychosocial support mechanisms. And coming to gendered shame, women with skin-neglected tropical diseases do experience disrupted marriages, abandonment, domestic violence, and their bodies, which are seen as just vessels of reproduction, now become contaminated symbols. They face forced isolation, they're sent back to their natal home is the mother's home, where they're said to go back, and they live their lives completely shunned by the community, seen as a curse. And shame is often interwoven with fear and control. So towards shame-sensitive intervention, so we need to build narratives of dignity and not just disease control. And we're looking to partner with local leaders to dismantle stigma myths and embed counseling and peer support into our national neglected tropical disease programs like National Leprosy Eradication Program. We're working very actively with the government to ensure that counseling and peer support can be provided at a local, state, and national level. And for this, we really believe that care must move beyond the clinic. It must reach communities. Because the psychosocial consequences, it really extends beyond what we can see within our hospitals and mere statistics. It really reshapes the social self, and it is a form of slow violence, and we've really seen its impact in individuals. We noted depression and anxiety to be prevalent in almost 3/4 of the participants, and 1 in 4 reported contemplating suicide. And 80% avoid any form of social interaction, such as visiting the temple, participating in village festivals or community events. And cultural and religious framing has been a big challenge for us to work with, because neglected tropical diseases are not viewed as diseases, right, that can be treated or addressed. Rather, they're perceived as, you deserve it, it's related to your karma, it's because of your spiritual impurity, and you are a source of family dishonor. So it's not that, you are having a disease, it's that you are impure, and there is a vast difference between these two narratives. So such interpretations again get reinforced by local religious leaders and even health workers, out of 2 reasons. 1, the religious beliefs that the health workers themselves hold, and even if they didn't, for fear of offending existing religious norms within communities. So conclusion. So Meena is just one, individual and one story. There are so many stories that are perhaps even, far too painful to be shared. And our work is a call to reimagine care, because care is not just in a medical realm, but it has moral, social, and human implications. And Meena's story sadly is not unique, and it's sadly not unique at all to India or Tamil Nadu. We've seen this affect a lot of resource-limited settings in Africa, Latin America. And shame does not end with a diagnosis. In fact, for a lot of individuals, that's where it really begins. Thank you so much for listening, and I'll be happy to take any questions.
Thank you very much, Monisha, for your very powerful presentation. We're a little behind time, but we're going to take some questions anyway, if people...
Thank you, Monisha, for sharing your work. I was just thinking aloud in my head as you were presenting. There are a few variables in my mind. One is shame is associated with poverty. Shame is associated with caste, where you are. Shame is associated with disfigurement rather than probably neglected tropical disease. I was wondering whether you've looked at disfiguring tropical diseases in the upper 2 castes in where you are.
Thank you. That's a fantastic question. In fact, this was something that came up during our discussions as well, is are we, leaving out a significant group of individuals. Disfigurement in the upper castes, manifests differently, because most often the information is not disclosed outside. Again, because within communities that they belong to, they want to be looked up to that, we belong to these upper castes, and therefore, we won't be seen as, because again, like I mentioned, when you get a skin neglected tropical disease, it's not seen as a chance that you get an illness. It's seen that it's a case of dishonor, or you deserve it because you belong to a certain caste. So within upper caste groups, we found that it's often shrouded in secrecy and not really accessible for us when we're working on research projects. So they have their own network of qualified doctors within their communities that they have access to, and they end up getting the care and rehabilitation. So in terms of whether it's accessible for us to study it, not so much, because it's by design, it's shrouded in secrecy, and the kind of rehabilitation that they experience is much better. But that would definitely be something interesting to consider, because I believe there's a different element to the shame that they experience, because there's going to be that conflict that say, I belong to this upper caste, but I'm experiencing this illness which is supposed to affect the lower caste. So that sort of a friction would definitely be something that's important for us to explore and address.
Online? We have an online question.
There's a question from Hamlata.
Can you hear Monisha? Can you hear Luna?
I'm sorry, I didn't catch that.
Sorry, the other mic wasn't on. There's a question online from Hemlata. Have you seen any correlation between shame and educational level?
Thank you. That's a great question. We, in fact, found a negative correlation. The more educated they were, we found that the shame they experienced was greater. So, as I mentioned, individuals with a lower educational level, there is a very strong belief that, this is what I've been assigned, this is what my karma has, given me. And so the shame that they experienced was far less as compared to an educated individual. The shame that they experienced with regards to the illness and seeking care was far more.
Any other questions? Can I ask a question, Monisha? So you've spoken a lot about gendered shame. How does shame manifest in male Indians of a lower caste?
Thank you. So this sort of yielded very unexpected results because shame experienced by men in the lower caste often has a very high correlation with domestic violence. So the shame is, in that case, the way they cope with the shame is not by isolating themselves, which is what we've observed in women. It's by inflicting violence, domestic violence, in the women in their family. So this can be their mothers, sisters, wives. So this was a different aspect, and which makes addressing shame even more urgent.
Thank you. One more question.
It's just me. I just want to say this was such a brilliant talk, Monisha, and thank you very much for sharing your research and your findings. There's so much.
Thanks for all that you do. Your work is fantastic and really inspired by it.
Very perfect. So thank you very much, Monisha. Okay, so we are a little bit over time. I feel no shame about being over time because I know I am constitutionally incapable of curtailing enthusiastic people talking about their work. Lunch is served where tea and coffee was, but you can take it and either go to the dining room or bring it outside. It is 12:14, but we will endeavour to be here for 1 o'clock to start again if people could do that. So thank you very much.